So let's go on and talk about foot and ankle, and we'll talk about the tendons. So we'll talk primarily the lateral, medial, anterior, and the Achilles tendon. Starting laterally, we have the perineus brevis and longus, which you're all very familiar with. Anatomy, they go behind the lateral malleolus. The brevis is anterior, the longus is posterior, and then the longus comes down here, wraps around the cuboid, and attaches to multiple bones here, primarily on the medial side of the foot, especially the base of the first metatarsal. Okay, and then on the MR images, we can see both the lateral side and the medial side, perineus brevis and longus, and then we'll talk about the medial tendons later. And we can follow them around here on the straight axial. This is T1 weighted images. We typically do an axial, straight axial T2 and a roughly 45-degree oblique coronal PD fat set, which is a nice view to look at the perineal tendons, especially the brevis at the level of the lateral malleolus. So there are a lot of pathologies involving the perineal tendons. Stability is important, tenosynovitis, tendinosis, interstitial tears, longitudinal split tears, and then transverse tears. The perineal tendons are held into their location posterior to the lateral malleolus by the retinaculum here, which we can see. You can get tears of the retinaculum, which can lead to lateral displacement of the perineal tendons. Type 1 is where you just have separation here between the lateral retinaculum and the cortex of the lateral malleolus, and the tendons can sublux into the defect between the retinaculum and the bone. Type 2 is a transverse tear of the retinaculum. Type 3 is an avulsion fracture of the retinaculum off of the lateral malleolus, and then you can have a less common posterior tear. So I think this is a case. Let me just. Okay, Tayson, what do you? We can see here that here's some of the ligaments which help hold the perineal tendons. We can see the brevis coming down to the base of the fifth, but here. This patient had chronic pain after an ankle sprain.
Okay, so are we seeing some stripping of the retinaculum anteriorly?
Well, we can see the retinaculum isn't very black here. Some increased signal intensity there. Here are the tendons. Now, this also is something we'll talk about. We're kind of proximal here, where the posterior aspect of the distal fibula is rounded. As we go more distally, it tends to flatten, and at the really level of where the tendons are abut the posterior aspect of the lateral malleolus, it really should become concave. And if we go more inferiorly here, we can see thickening and increased signal intensity within the lateral retinaculum. The tendons are here posterior to the lateral malleolus. And we can kind of come down further here, and we can see marked thickening here of that lateral retinaculum. And then go more inferiorly, and it's looking a little bit more normal in through here. And this was an old retinacular injury that healed with scarring. But that can actually produce chronic symptoms with kind of pressure impingement on the perineal tendons. Roberto.
All right, so we have, looking at the perineal tendons on the image on the right, looks like they're sublux laterally.
Right. So what do you think of the retinaculum?
I think it's insufficient. It's not holding the perineal tendons in.
Right. So when you have an insufficient retinaculum, can be congenital or can be due to trauma. then you can get this lateral dislocation of the perineal tendons, and then you get a frictional tendinopathy of the tendons, and this can be very symptomatic, and this is pretty common. So you'll see this not infrequently. Good. Okay.
So we have like lateral and like anterior dislocation, like go all over
Okay.
of the perineus brevis,
Yeah. So
and then signal.
yeah. So you can follow this down. This is probably going to be the longest.
Oh, that's the longest.
But well, you can't really tell here. You need to follow
I
where
see, I
where it
see.
goes, and then this is probably going to be the brevis. This is probably the brevis muscle here. But why in this case do you think that there's a dislocation of the perineal tendon?
Because you just said it. There's not concave
Okay, right.
bone
Yeah.
like that process.
So here, and this is a risk factor for instability, is if you maintain a concave posterior aspect of the lateral malleolus all the way down to the tip of the lateral of the fibula, then this tends to, if you have force on the traction on the tendons, it forces them anteriorly, and if you have a slope here, then it'll tend to force them into the retinaculum, producing that type 1 tear of the retinaculum where it attaches to the bone, and you get subluxation of the tendons, which is what's occurring here. And in the coronal plane, you can see the tendon is lateral to the lateral malleolus, not posterior where it should be in this particular case. Oh, so you were right, it's the brevis. I thought it was going to be the longest, but it turned out in this case to be the brevis. Good. Which is easily determinable if you have the rest of the images. Okay. And these are usually palpable. People tend with flexion extension to get popping. So it's a fairly easy clinical diagnosis. And you can confirm some of the reasons why with MR.
Okay, so here on coronal views, we have dislocation of the perineal tendon.
Yeah. And then here are the axial images here. And again, we have this convex posteriorly shaped to the distal fibula, and the lateral displacement or subluxation of the tendons. In this case, this was the longest and this was the brevis, but both of them are a little bit laterally displaced. Okay, Tayson.
All right, so looks like we have edema at the distal fibula, and split tear of the peroneus brevis.
Right. Good. And this is one of the most common abnormalities that we see of the perineal tendons. It's just tenosynovitis, but then the split tear of the perineus brevis. The brevis is anterior, the longest is posterior. When you've put tension on the tendons, it tends to pull the longest into the brevis, and over time you can produce a midline split tear within the brevis due to the longest. And then if you have a lot of rubbing on the bone, you can get secondary edema within the lateral malleolus, and the bone edema both correlate with pain. There tends to be a little bit more pain when you see the bone edema, but split tears tend to be painful lesions. Robert.
All right, we have a 39-year-old with a twisting injury, and the orthopedist told her that there was either a perineal tear or it was subluxing. And yeah, it looks like there's some anterior dislocation of one of the perineal tendons, probably the brevis.
Yeah, this is from Dr. Tierman. And what do you see here on the axial images?
Yeah, it looks like there's disruption of that retinaculum and there's lateral dislocation of the tendons.
Right. And here we can see on the coronal images. Good. Okay. I guess we're beating a dead horse here.
Um, so it's again the uh, anterior dislocation.
Okay, so
of
there
the
we see the
tendons.
dislocation
Yep.
of both of the tendons
Both the tendons.
laterally.
I mean,
I
I said
retinacular
anterior.
tear. Good.
Anterior lateral.
Okay, on x-rays, this patient had calcification in the area of the perineal tendons. And what do you see here?
Yeah, it looks like the posterior aspect of the lateral malleolus looks like there's a hook there. So yeah, very irregular and subluxation of the perineal tendons.
And then here we can see calcification on the CT scan here. So this is really a congenital anomaly with involving the distal fibula, which is going to lead to instability, tearing of the retinacular attachment to the fibula. In this case, a lot of chronic injury and calcification, dystrophic calcification in the area of the tendons. So chronic subluxation. Tayson.
All right. It looks like we're pretty proximal here, and the tendons look enlarged. Is this a complete tear with retraction?
Well, we just see that here. This is probably the tendon sheath here. It's markedly expanded. There's a lot of edema and soft tissue structures here. Do you know what this is?
Is that a peroneus cordis?
I'm sorry, what?
Is it a peroneus cordis muscle?
No.
Is that the myotendinous junction?
No, that's not, I'm blocking on the name of it now. I'm sorry. It's basically attachment, often has vessels in it that goes to the tendons and is a connection between the tendons and the synovium. And I'll think of the name in a minute. I'm sorry. So here we're down now by the lateral malleolus.
Yeah, a lot of fluid and synovial thickening.
Yeah, a lot of synovial thickening here. So this really looks like there's a rip-roaring synovitis here, probably chronic. What do you think of the sagittal hemorrhages?
Yeah, a lot of synovial distension, thickening.
Okay, and if you give contrast and scan farther down, this is what it looks like. And here.
Nice.
Okay, so this is basically a lot of synovial thickening, and there's fat within the synovium. So what does that make you think about?
It's like, okay.
Wow.
So this is lipoma arborescens within the perineal tendon sheath. Okay. So other diseases which can cause disease within the perineal tendon sheath, there's rheumatoid arthritis, psoriasis, diabetes, and hypothyroidism are all associated with disease in this particular area. As far as associated anatomic variants, there's several that we've talked about. One's a perineal tubercle. It's a little bit more distal, but involves the perineus longus predominantly. Non-concave retromalleolar groove, which we saw that's a convex retromalleolar groove tends to lead to instability, whereas concave is stable. You can have an os perineum. It's an ossicle within one of the tendons, probably not congenital, but most of the time due to prior injury. And you can also get a perineus cordis muscle, as somebody referred to earlier, along with the perineal tendons. Okay, Robert.
All right. Here it looks like there's a lot of edema surrounding the perineal tendons. There's some thickening of the perineal tendons.
Right.
Some partial thickness tearing at least.
Yeah, and so this is distal tendon, and the patient had perineal tenosynovitis. Again, it can be due to any of the inflammatory conditions we talked about, or you can get it due to trauma and either longitudinal split tearing of the perineus brevis or tearing of high-grade partial tearing of the other tendons or the perineal longus. And then here's also patient very old scan where there's a cyst within the perineal tendon sheath. Okay.
It's like a thickening of the sheath, like of the peroneus brevis.
Well, let's see. So you're
Is
looking
it-
at this,
Yeah,
right?
I'm looking at this. Yeah,
And it's thickened here.
yeah. Is it like a nerve thickened?
Well, what do you think this structure is?
What is this structure?
What structure is that that's abnormal here?
Um,
Okay, so it's
like
it's,
the os peroneus, I think. No, what is it? It's
well,
like,
this looks like it's in the perineal tendon sheath,
mhm.
and this looks like it's anterior. So this is thickening and increased cell intensity, primarily involving the perineus brevis tendon, right?
Yeah.
And this was a high-grade partial tear of the perineus brevis tendon.
Mhm.
Okay.
By itself.
Okay, so here, looking at that peroneus brevis tendon, it looks curvilinear. The image on the left is moving more distally. It looks split there, and that image in the middle.
Right. And as you can see, it's split into a medial and a lateral component. So this is a very common injury pattern of the perineal tendons, which is a longitudinal split tear of the perineus brevis. And the main reason that we like the oblique coronal PD fat set images, which has close to a 45-degree angle with respect to the usual coronal plane, is that it really gives us a nice cross-sectional view of the perineus brevis in the part of the tendon going right around the malleolus where you tend to get early split tears where they start. And it increases our sensitivity for looking for these tears. These are usually very symptomatic in young individuals. And with straight axial imaging, sometimes they can be pretty difficult to see, depending on how good a contrast you have and how chronic they are in this area. So that's a longitudinal split tear. Okay, Tayson.
All right. Looks like you have kind of a C-shaped appearance to this peroneus brevis. I'm not sure if it's split or not, but definitely at least a high-grade longitudinal.
Here's farther down.
All right, so now I think it is split.
There, and then the longest is here. Okay, and if we go to the sagittal images, we can actually see that there's actually abnormal longitudinal signal within the longus as well. They actually went to surgery here. And here you can see the split in the tendon. The tendon split on either side. One's here, one part of the tendon goes on the other side. And here, just all this is stranding. And in that case, you saw you had a leg of the thickened perineus brevis. This is what it looks like. This is kind of what it looks like on the MR scan. If you go back, it was thickened with these kind of little dots of collagen, low signal intensity collagen with a lot of granulation tissue in between. And that's what it looks like. And this was perineus brevis split tear with a lot of tendinopathy within the tendon, and there's myxoid degenerative disease, which they debrided at the time of surgery. Okay. I'm sorry, who's next?
I think it's me.
Go. Okay, Robert, good.
Here, let's see. Looking at the perineal tendons, there's a lot of fluid surrounding the tendons, and I think there's at least partial thickness tearing of one of those tendons.
Yeah, what's all this stuff back here? So we have fluid up here, and then we got some other stuff back posteriorly. If we go farther down, this is what it looks like.
Okay, so there I only see one perineal tendon.
Right. So this was actually a complete perineus brevis tear with retraction, with a lot of tendinopathy and thickening, and also there was some instability, I think, here. And you can see a lot of fluid there, a lot of tenosynovitis due to the tears. Good. Okay. I think we saw this case earlier, a couple of days ago.
Like the tendon going through the bone. You're saying that's surgery, right?
Yeah, so,
Yeah.
so we see a kind of a hole in the bone there. If we do the
Mhm.
axial images,
Yeah.
there we see it. If we go to the sagittal, what we see is the brevis is coming here from the base of the fifth up into a tunnel within the lateral malleolus where it's fixed on the other side, and this is the longest coming down here. So you remember what we called this?
The name of the surgery?
Yeah. Do you remember? But this is a slightly different case, but
It is different, yeah.
so this is a perineus brevis
Tenodesis.
tenodesis in this case. Jones, thank you. So this is one of Jones's many surgeries that are named after him. Okay, thank you. Okay, then we can look at the perineus longus, and it could typically tears at one of three locations: at the level of the lateral malleolus, at the perineal tubercle, and the region of the cuboid. That's where it goes around bony eminences each of those times, and you get rubbing of the bone, the hard structure, against the soft longus tendon. Here's just a CT reconstruction showing the perineus longus coming down. This is the level of the lateral malleolus. Here's the level. If you have a perineal tubercle, that's where it would be. And here's where the longus goes around the base of the cuboid. So those are the three locations where you look for injury patterns to the perineus longus.
Right, so posterior to the peroneus brevis, yeah, we just see, can't really make out a nice tendon there. There's just soft tissue thickening. Yeah, the peroneus longus, it looks like there could be a tear, maybe.
Yeah, I think this is actually a full thickness tear with proximal retraction.
Okay.
When I first put this in, I thought it was an injury at the level of the lateral malleolus, but I think this is a more distal injury with proximal retraction of a full thickness tear of the longus. And you can see a lot of degenerative disease. As you remember, we talked about best studied in the shoulder, but almost all tears of the tendons are in areas of severe tendinopathy of the tendons. So they develop the degenerative disease and the tendinopathy first, and the tear comes second once you weaken the tendon with tendinopathy. Okay, Tayson.
All right.
So this was a calf mass.
Calf mass.
Yeah, baby cow mass.
So there's peroneal tendons I see, but there's like a low or heterogeneous structure anterior to it. Is that just a severely tendinotic?
Okay, and we've got edema around it. Okay, let me show you some other images.
All right, is this
It's a coronal image.
retracted tendon?
Okay. So this looks like there's some rope that's balled up in the calf here near the distal musculotendinous junction. Maybe these are those components in that location. If we go to the sagittal plane, this is what it looks like.
Yeah, it looks like a retracted tendon in the
And if,
favorable reverse S.
and if you go down to the lateral malleolus,
Oh yeah, I don't see any peroneal tendons there.
right. So this was a perineus longus rupture with retraction, and the mass was the retracted tendon. Okay, Robert.
All right. Another, looking at the image at the left, it looks like there's a prominent perineal tubercle, and then the perineal tendon posterior to it looks fairly normal.
Yeah, and again, remember, the perineal tubercle is always anterior to the longus unless the longus is displaced. Brevis is anterior to the perineal tubercle. And on the coronal images, we can see a nice prominent anterior perineal tubercle here with the brevis on top and the longus on the bottom. And if you see here, this kind of bowstrings the perineus longus, and therefore with flexion and extension, you can see that this hard structure could rub against the longus, producing tendinopathy and symptoms. And here's a marker showing where, right next to where the symptoms were. And you can see a little bit of signal intensity here within the perineus longus. So that's a perineal tubercle. There have been some studies published about whether these are symptomatic or not, which are quite confusing. The perineal tubercles are not rare. The vast majority really aren't associated with symptoms. So there are papers that have only a few perineal tubercles in them that I don't think have the size to actually pick up symptomatic perineal tubercles who say that the perineal tubercle is really not associated with symptoms. If you had a study powered high enough to actually depict it, I think that this is a significant cause of lateral ankle pain can be. And the things you look for symptoms are edema within the longus tendon in this location, which we don't really have here. And more importantly, edema within the perineal tubercle. And I think bone edema within the perineal tubercle is pretty highly associated with symptoms. Not 100%, but that's kind of what you look for to try to determine whether it's really a clinically significant finding, that and a marker right next to it showing where the pain is. Okay, Oleg, is it your turn?
It's like a strange appearance of that tubercle. It's like
Okay, so
elongated.
here we see
Yeah.
this is on CT scan, another
Mhm.
perineal tubercle, which is very sclerotic,
Mhm.
irregular margins, and maybe some thickening of the longus tendon here, the brevis in front. So this is what CT. CT is obviously not great at looking throughout soft tissues, but this is really kind of a bizarre appearance. Looks like a lot of degenerative change to the cortex here. So this is likely to be a symptomatic perineal tubercle.
Hmm.
Okay, so here we have a kind of large perineal tubercle with irregularity of the peroneus longus tendon behind it.
Right. So this is a typical kind of tendinopathy you get, and it looks like the tendinopathy we see elsewhere in tendons, and typically due to traction and or abrasion type injuries to the tendon. And this was a symptomatic tendon uh, in this location. Tayson, what do you think about this case?
Looks like we have a severely tendinotic peroneus longus, probably with some tearing as well.
Yeah, the brevis is probably abnormal here as well. Okay, and what else do you see?
Is there a defect right there? Like it's been a tubercle's been resected?
Okay, well, let me go to the coronals. Here's what the coronals look like.
Okay. Edema within the tubercle?
Okay, so there's a lot of edema here. There's also abrasion of the cortex in this area, right adjacent to the longus tendon, which is very abnormal. Some tendinopathy in the brevis, but this was a very highly symptomatic. You can see there's a lot of edema in the surrounding soft tissues. This is a symptomatic uh, perineal tubercle here with all the bone edema that really looks like the bone is really irritated.
Okay.
Okay. Robert.
All right, so we have a 25-year-old female with lateral calcaneal pain. Looks like there's a perineal tubercle and the tendons adjacent look relatively okay, but there's some edema in that perineal tubercle in it.
Okay, not the world's best study, but this is 2008. And we can see there's some edema here in the perineal tubercle. So this was 1/10/2008. The patient came back a year later, and this is what it looked like.
Now it looks like there's increasing edema within that perineal tubercle and maybe some scarring associated with the perineal tendons.
Yeah, what happened here, they actually went in and resected the perineal tubercle,
Okay.
and we still have some edema and irritation of probably scar tissue in the area of the surgery.
I see.
It's right where they're symptomatic. But this is postoperative from a perineal tubercle resection. Oleg? Oops.
Um, and this perineal tubercle is like too small, I guess. Yeah, so everything is in front.
Oh, so the question then is, what is this bony prominence here? So you would call it a perineal tubercle?
Yeah,
Okay.
it's like small.
Okay. And I've actually seen this called a perineal tubercle in a number of publications in radiology, but this is the perineus brevis tendon. This is the perineus longus tendon. The perineal tubercle should be between the two. And this is actually called the retrotrochlear eminence, which is a normal finding and is not really associated with clinical symptoms. And this is really actually where the perineal retinaculum attaches to the bone, and you can get kind of a traction prominence in that location. So this is a normal finding, and there is no perineal tubercle here. So it's important to differentiate this because it can be confusing and is a fairly common mistake. Okay. And then we can go down to the level of the cuboid and distal to that. And the cuboid is here, the longus comes around here, and you can get edema and tendinopathy in the distal tendon. This is from the literature. So let's see, Helior, what do you think of this?
Okay, looking at the middle image, the peroneus longus as it comes under the cuboid looks tendinotic. Not sure if it's torn, but
So here's before it gets in there, and now it's at the level of the cuboid, and here's distal to the cuboid, really more in the plantar to the cuboid and through here, where it's going to extend across and attach right over there. And if we go to the sagittal images, you can see here's before you get into the cuboid, at the level of the cuboid, and then distally, you can see it's markedly thickened and increased signal intensity within it. So this is tendinopathy of the longus at the level of the cuboid. Same patient, we can see edema within that distal tendon. We can see it's thickened with edema here. We can come around the cuboid down and through there. And then this is actually at its insertion here. coming across in this area. We don't see it very well, and that's because it's very edematous in here. So that's a distal disease within the cuboid, distal to the cuboid. Okay, Tayson.
All right. Looks like we have a severely tendinotic peroneus longus tendon.
Yeah, so this is a very diffuse injury all the way along the course. Right.
Yeah.
Okay. Robert?
Let's see. It looks like there's maybe some increased signal in that distal perineus tendon, and then is there a small ossicle there?
Okay. So here on the T1, we see some fat signal. The fat suppressed, it suppresses. And here we can see fat there. So this is a perineal ossicle. So this is really listed in Keats' book on kind of normal variants or congenital. But let me show you this case. Oleg, what do you think of this is actually the location of the distal perineus longus tendon right in through here.
So like diffuse thickening, like maybe like tear.
Okay,
Tendon.
good. It should be black.
Yeah, it should be
What
black,
this
yeah.
is was a partial tear of the tendon. If we go to the PD fat set, oops, this is, yeah, okay. In this location, I guess I don't have the PD fat set image there, but this was interpreted as a partial tear of the distal perineus longus. Then the patient came back 4 years later, and this is what that perineal
So
tendon.
ossification, right?
Okay, so this is a T1 weighted image like the last one, which did not show fat in this area. And here we can see this looks like a corticated area of fat, which suppresses with PD fat set. And this is a patient who came in, and here we can see it on the coronal images, patient who came in with basically a partial tear, but no evidence of an ossicle. And then 4 years later, the tear repaired itself, and now you've got an ossicle in that location. So I think a large number of these, as we've talked about before, are due to prior partial tears that healed. Okay.
Right, so we have thickened peroneal tendons. Looks like there's an ossicle within the tendons.
Right where the markers are located.
Yeah.
But this is a little bit different location. This is very proximal. This is a very unusual location for a perineal ossicle, but this is a more proximal one. And you can see that there's marked abnormality in the tendon. It's markedly thickened. So this is probably another example of where you've had an injury to the tendon, and part of the healing is with ossification within the tendon.
Okay.
Okay. Asen.
All right. So see this focus of increased signal. Is this potentially an edematous os perineum?
Well, this is the fifth metatarsal. Remember the perineus brevis tendon attaches to the base, so we're not in the area where you have perineal tendons anymore.
Okay.
So we're talking about a different tendon here. Be lateral to the fifth. Here we can see fluid in this location here, and this was a tear of the adducti digiti minimi tendon.
Okay.
All right. Robert, go-go dancer.
Go-go dancer.
All right, so left foot pain in a go-go dancer. Looks like maybe a little bit of edema in that. Okay, I guess in the region of the fifth. Yeah.
Here's a marker here.
Okay.
And then we see that there is a lot of soft tissue thickening
Mm-hmm.
in this area.
Yeah.
Okay, if we go to the sagittal images,
Oh, yeah, it looks like there's a vocal discontinuity in that. Is it the adductor digiti? Minimi?
okay, right in there. And this was a tear of the adductor digiti minimi tendon. Okay. Look.
Um, so a lot of edema in area where that's supposed to be the tendons.
Okay, so we're
Like-
seeing a lot of degenerative disease here.
Degenerative disease,
Flexion
yeah,
area,
and then
and a lot of soft tissue thickening here, which
like-
is displacing the fat or replacing the fat
mhm,
over in the area inferior to the lateral malleolus. All this here probably involving the sinus tarsi area, all into there. Some bony erosive changes, something that we've seen in the past with something like rheumatoid arthritis. But this turned out to be post-traumatic scar in someone who has lateral impingement that we'll talk about later. And that's obscuring the perineal tendons, which are involved with severe tendinopathy in this particular case. So this kind of brings us to the tarsal tunnel syndrome, which you talked a little bit about earlier. Again, there are a number of different definitions. It's basically pain in the region of the sinus tarsi, medial arch of the midfoot. It's also commonly associated with heel pain and plantar numbness. Differential diagnosis, 50% of the time it's idiopathic. Can also be associated with tumors, tears of the trauma is probably the most common. We have tears of the ligaments, which leads to instability and scarring and degenerative disease in that area. So now let's move on to the medial tendons, which are the posterior tibialis, flexor digitorum longus, and flexor hallucis longus. And if we look in the axial plane, we can see these three, posterior tibialis, flexor digitorum, flexor hallucis, coming across there. The size of the posterior tibialis tendon is the largest of the three, and roughly the cross-sectional area in the axial plane of the posterior tibialis should be roughly equal to the sum of the cross-sectional areas of the digitorum and hallucis longus. It's kind of a rule of thumb that you can use, because increase in the size of the posterior tibialis tendon is one of the criteria that we'll use for tendinopathy of the tendon. If you go distally, it comes down and attaches to a bunch of bones over here medially. A major attachment is going to be the medial margin of the navicular bone, but it also attaches more distally to the cuneiforms as well, coming across there. And then if you look in the sagittal plane more laterally, this is the typical course of the flexor hallucis longus coming underneath the cestum taculum talus, as you know, and then obviously the Achilles and the plantar fascia origin inferiorly. Now, this is another study that McGonigal and all did, pathologists, that they published in Arthritis and Rheumatism, looking at the structures here involving the posterior tibialis tendon, and this is pretty much true of anywhere where tendons are associated with bony eminences that they rub across. This is also true of the details if you look carefully at the perineal tendons. You have the bone here. On top of the bone, you have a periosteal fibrocartilage only in the area where you have rubbing between the two, and you end up with a kind of a fibrocartilage also different biochemical structure of the tendon in this location so that these can handle rubbing against each other with less injury to the collagen fibers of the tendon. And then you have a synovial cavity here, which can fill with fluid when you have tenosynovitis. And then you get some other cartilage formation and membrane. And here's the basic tendon. And so this is, and then if, as I said before, there are multiple attachments of the distal posterior tibialis, the navicular, but also to the medial cuneiform and the base of the metatarsals, as well as, this is very variable, but you can also have strands that go all the way over to the cuboid to help, and then also back here to the calcaneus to help stabilize the distal insertion of the posterior tibialis. As we'll talk about, it's a very important stabilizer of the ankle. And here we can see a case where the posterior tibialis is coming down here. It looks like there's kind of a mass here, the distal part, and again, looks like kind of a mass, often with a little gray signal intensity here, very near the attachment to the medial navicular bone. Thank you. and this is very variable. This turns out to be fibrocartilage. It can be not prominent at all, and you have the tendon directly attached to the medial part of the navicular, or it can be a prominent thickening. It can be black. It can be gray like this, or it can be ossified. And when it's ossified, we call it an accessory navicular, of which you're all familiar with 1, 2, and 3, which we'll further talk about either in this talk or the very next talk. But this can be very variable in this location. This is also adjacent right here to the superior oblique portion of the spring ligament, which comes up as a sheet in this particular location. So this is normal. Okay, I don't remember who's last. Anybody else? Okay, Eleanor's going to take it. Go for it.
Okay, so we're looking at the posterior tibialis tendon. Yeah, on that sagittal view, maybe a little tendinosis, surrounding edema, maybe tenosynovitis.
And here's the axial view, hallucis longus, digitorum, posterior tibialis tendon.
Yeah, tendon looks intact. Is there some osseous structures anteriorly, or
Here's a marker where the pain is.
Mm-hmm.
So there we can see fluid in the posterior tibialis tendon sheath, which, especially when it's symptomatic, we tend to call tenosynovitis. Here we can see that there's actually increased signal intensity and some kind of stranding of the distal posterior tibialis tendon. So we typically call that tendinopathy or tendinosis. And this is typically what you see with posterior tibialis tenosynovitis, where you get an inflammatory reaction, probably due to the collagen disruption within the tendon, which then leads to display of abnormal portions of molecules within the tendon, which leads to inflammatory response and inflammation and tenosynovitis. And posterior tibialis tenosynovitis is common and significant. If you look for the amount of fluid here, this was a study where they looked at how much fluid is too much fluid. And here they said if you measure 9 millimeters, and really along the PTT, this is actually in the wrong, this is digitorum. Less than that, this is abnormal fluid in the digitorum as well. Fluid in the hallucis longus is quite common, and even a fairly large amount of fluid in the flexor hallucis longus tendon sheath is considered normal. Mm-hmm. But it's abnormal in the posterior tibialis, and this amount in the digitorum would be abnormal as well. But what this study says is if you could measure a length, cross-sectional length of 9 millimeters, that's abnormal. I think most people will actually call it abnormal when there's less fluid than that. Okay, Tayson.
All right, so looks like we have a lot of soft tissue distension and thickening within the posterior tibialis and flexor, or the flexor digitorum sheath.
Okay. Yeah, so this is the more chronic phase. Probably due to chronic inflammatory disease, you get a fibrous response, healing response, and you end up with marked fibrous thickening here. And this is chronic tenosynovitis, chronic tendinopathy. And this is the kind that's often associated with the kind of instability we're going to talk about in the next lecture. Okay. Robert.
This looks like a bone scan, and it looks like there's increased uptake in that.
Yeah. I don't know why I have this in here. It's really from the really old days when we did bone scan for these. Here you can see this is uptake really is involving the medial part of the navicular, and this was just shows that you could get increased bone turnover in this particular disease due to the traction injury from the abnormal posterior tibialis tendon. Right. Okay. Oleg, this is another patient.
It's like I think it's type 1 os navicular.
Okay,
And,
good. So here's the posterior tibialis tendon.
Yeah.
It's attaching to this bone, which appears to be retracted from the navicular here, right? And you're right. I think that's an accessory navicular, and there's separation of the syndesmosis between the probably type 2 os naviculare and the navicular bone itself, which can be a symptomatic lesion when you tear that syndesmosis. Good. It could also potentially have been a type 3 where you have a fracture and an avulsion fracture of a type 3. But in this case, I think it was believed that this was a retraction and tearing through the syndesmosis, not a fracture of the bone itself.
Okay, 21, medial foot pain. On the radiograph, we see an accessory ossicle, the navicular, medial navicular there. And on the MR, yeah, I think the stir image on the bottom, we see some edema in that os navicular.
There are probably two of them here, and we definitely see edema in that, right? And axial images. You can see a lot of hibernation, the degenerative change here at the syndesmosis with some bone edema. Yeah, and so that was a symptomatic accessory navicular. Here's another case where we have similar with a lot of bone edema. And again, this is a case where bone edema is highly associated with symptoms at this location. And it's called a painful type 2 accessory navicular bone. And you really look primarily, it can be associated with pain, it can be associated with dysfunction. And a really good indicator of dysfunction and pain is the bone edema associated with it. And here's a paper showing that. Okay. All right. Tayson.
All right. I guess this is a type 2 os navicular with some degeneration at the synchondrosis.
Okay. Let's see. Here's what it looks like in the axial plane here with a lot of edema. Yeah. Here's in the coronal plane. a lot of edema. Here's the cortex. And this was actually an avulsion fracture.
Okay.
And maybe it was a kind of a small type 3, but here you can see that here's the cortex of the parent bone going around it. Maybe it's a little type 3 with an avulsion fracture. Okay. Robert?
All right. Let's see. Looks like there's a lot of increased signal in that distal PTT. Yeah, I'd be concerned about a tear.
Okay. Here's the hallucis digitorum. Oops, where's the PTT? Right? And that turned out to be a complete rupture of the PTT. Okay. Let's see, last case. Like, what do you think here?
So there is a
Yeah.
thickening, increased signal in one of the tendons there.
This, are you talking about this?
Like below that.
Below that, down here?
No, in between.
Here?
What's that?
Well, this is a flexor hallucis longus going
This
up
is
to the
already
flexor
okay.
pectorum talus.
And that's just fat.
This is just a fat.
Oh, just a
tissue.
fat. Okay.
What I'm concerned about is
Oh, okay.
there.
So it's like a retracted tendon, or
Right. Exactly. So this is a complete rupture
I
of the
see.
posterior tibialis
Okay.
tendon with retraction. Why don't we stop here and we'll talk about what the impact is of chronic posterior tibialis tendinopathy the next lecture. Now, let me just see here. Today is Tuesday. Okay, so we'll probably have lecture on Thursday. We'll not have lecture on Friday. And I'll be gone all next week except for Tuesday. So we'll have to see on Tuesday whether we have lecture on Tuesday. Okay? So I'll let you know on Thursday whether we have lecture. Okay, thanks.
Thank you.
Thank you.